at the end. I hope that's okay. So if you guys could, oh, there's also a Minty, but I'll get that up later because that's quite technically difficult for me. So I'll get that up later and post the code in the chat. So yeah, so what we will do is, this is to start the case. So there is a 27-year-old woman called Cleo who has come in with vaginal bleeding. Her last period was 6 weeks ago, and she took a pregnancy test 1 week ago and was positive. So what could the possible cause of her bleeding be? If people just comment in the chat what they think is going on. Any ideas, anyone? Or you can speak if you want to. Ectopic pregnancy, it could well be. Any other options, anyone? Miscarriage or ectopic, yeah. Okay, so she could have early pregnancy bleeding, which can be caused by physiological. So it is very common for women to get bleeding during pregnancy for basically like no reason. So there's some people say it's like implantation bleeding, but a lot of the time they don't actually know what's causing it. I think up to like 30% of women who having like a normal pregnancy will get bleeding. It could also be miscarriage. So as someone has said, it could be due to a miscarriage. It could be ectopic pregnancy. It could be a molar pregnancy, which is an important differential to consider. Both molar and ectopic are. And then it could also be like non-pregnancy related things. So for example, like an ectropion, which are more common in pregnancy. So that's something important to remember. Ectropions are more common in pregnancy. And they can also cause bleeding. You could have a cervical polyp, which could cause bleeding, or it could be some form of cancer. So I know people are pregnant, but it's always important to make sure you consider like non-obstetric causes as well. So like normal gynae causes. Okay, so the case continues. A pregnancy test is repeated in hospital and comes back positive, but a transvaginal ultrasound is performed and nothing can be visualized within the uterus. What is this called? And what could the underlying diagnosis be? Any ideas? Okay. Can you still see the screen as well? I'm trying to get, yes. Pregnancy of unknown location, fantastic. So this is a pregnancy of unknown location. And this basically is a working diagnosis when a pregnancy test is positive, but there are no signs of intrauterine or extrauterine pregnancy on the transvaginal ultrasound. So there are basically 3 different possibilities for this. First one is a very early intrauterine pregnancy. So usually pregnancies can only be visualized after 6 weeks. So it could be a normal pregnancy, it's just not, you can't see it yet. It could be a spontaneous miscarriage. It could be a very early ectopic pregnancy, so the same thing. An ectopic can't normally be visualized until around 6 weeks, not 8. The most common cause, however, is a miscarriage. So that's one thing to be aware of, but it could be either a miscarriage, a normal pregnancy, or an ectopic pregnancy. So pregnancy of unknown location. So basically what happens is the pregnancy test is positive, but when you do a transvaginal ultrasound, you can't see anything. Does anyone know why we do a transvaginal rather than a transabdominal? When would you start doing transabdominal ultrasounds? Anyone know? What gestation? Okay, you start doing transabdominal usually around 12 weeks because before then it's too hard to visualize anything, and anything you can see is just too tiny to like make out anything reasonable. So what happens is you do consecutive, in a pregnancy of unknown location when you can't see the pregnancy but the pregnancy test is positive, you will do consecutive beta HCG readings. So they're usually 48 hours apart, and you can do them for like 6 days or however long until you kind of get an idea of what's going on. So if the initial reading is above 1,500, a viable uterine pregnancy is unlikely, and it's most likely that it's outside of the uterus, and therefore it's probably an ectopic pregnancy. So that's something to note if the first reading is really high. If there is an increase in the serum HCG of 63% over 48 hours, it's likely to be a developing intrauterine pregnancy because the HCG normally doubles every 48 hours in a normal pregnancy. So the advice is in this case to repeat the ultrasound in like 7 to 14 days time or somewhere between that, and then you should be able to see the pregnancy. If it decreases by more than 50%, it is likely that it is a miscarriage. Because the level usually halves every 48 hours in a miscarriage. And then if it changes between these limits, so it like increases but not by 62%, or it decreases by not 50%, it's likely to be an ectopic because there's a suboptimal rise in the beta HCG in this case. And these women need to be sent for an assessment in the early pregnancy unit within 24 hours. And if after doing that, you still can't get an idea of where the pregnancy is, or you still can't see it after a couple of days' time or a week's time, you should go for a laparoscopy and you basically look for the pregnancy. But that's very rarely done. Has anyone got any questions on that? If you do, put them in the chat, or feel free to turn your mic on. So upon further questioning, Miss Jones reveals that she has some pelvic pain, which also started the morning of the bleeding. A bimanual examination is done and then it reveals unilateral adnexal tenderness. Miss Jones also reveals that she had pelvic inflammatories twice in the past. So what are you most worried about, given this history? Any ideas? Any ideas what you've been ectopic pregnancy? Yeah. So you're most worried about an ectopic pregnancy. Does anyone know why an ectopic pregnancy is worrying? Like why would you be? We'll go on to discuss it, but anyone got any ideas now? Okay, we'll come back to it. So, yes, ectopic pregnancies are worrying because of the chance of rupture. So I'll come on to it in a second. But basically, an ectopic pregnancy is a pregnancy which is implanted outside of the uterine or endometrial cavity. So it's normally divided into two groups, which is tubular ectopic pregnancies, and this is what most pregnancies are. And so these occur within the fallopian tube, usually the ampulla. And that's the most common type. And it's worth noting, particularly this is more for SBAs, that an ectopic in the isthmus is the most likely to rupture. Like a question like, oh, this lady's got a ruptured ectopic, where is it most likely? It's most likely in the isthmus. It's just a random fact, but it's for SBAs. Then the other type is non-tubular, and this is basically everywhere else. So the ovaries, the abdominal cavity, C-section scars, cervix, and interstitium of the uterus or the tubes. So non-tubular pregnancies, the most common location is in the ovaries or the abdominal cavity. And some of these can actually go on to term, like you could carry the pregnancy to. There's a risk of hemorrhage, like major hemorrhage, which is really hard to stop because of the location. So normally, a termination is usually offered to these women, and they wouldn't be advised by medical staff to continue the pregnancy because it's high risk of hemorrhage and lots of complications. So risk factors. Anyone suggest any risk factors? I mean, there was one we mentioned in the case, but anyone else got any other risk factors? Anyone suggest any risk factors that make ectopic pregnancies more likely? Yes, previous PID. Structural damage to the tubes, yep. IUD, good one, yes. Okay, so the ones I've got are fallopian tube damage, because this basically interferes with the transport of the egg. So this is things like a previous ectopic pregnancy increases the risk. Yeah, good one, Miguel. Previous ectopic. Having a previous PID. Endometriosis, so someone's already said that as well, yep. And then having previous tubeless surgery. So particularly, so sterilization is a procedure you can do in women. It's not usually reversible, but some rogue surgeons privately may reverse it. That's really high risk for ectopic. Also IUD and IUS in situ. So the reason these increase the risk of ectopic is because there's something within the uterus, so the egg is less likely to go into the uterus and more likely to stay within the tubes. And then assisted conception, like IVF, has a higher proportion of ectopic pregnancies than normal pregnancy. And ectopic pregnancies make up about 1% of pregnancies in total, so they're very rare, but you need to be aware of the signs because, as someone said earlier, they have bad complications and consequences. So symptoms. Anyone suggest any symptoms? First, of an unruptured ectopic. Right iliac fossa pain, yep. Or left, it doesn't have to be just in the right, yes. However, it is a good thing to make sure you're aware of that if someone presents with right iliac fossa pain and they're female, you can't just think appendicitis, you've got to think that there's an ovary there. So it could also be. That's a good point, Izzy. So the ones I came up with are, they usually present 6 to 8 weeks after your last menstrual period. So that's kind of, if for SBAs, that's important. If someone had their last menstrual period like 7 weeks ago, start thinking ectopic because that's usually the time they present. You get lower abdominal pain and pelvic pain. The pain in the abdomen is usually one-sided. So yeah, it's usually one-sided, and make sure if it's on the right that you think about appendicitis, but also if you're thinking appendicitis, you should also be thinking about an ectopic pregnancy in a woman. You get PB bleeding. It's described as light, scanty, dark brown discharge, and it's usually lighter than a period. So you should ask a woman that. It's usually lighter than a period, and that's basically just due to like the low levels of beta HCG. You get signs of pregnancy. So women may say, oh, I haven't had a period, my last period, I skipped it. And they may get things like breast tenderness because they are pregnant, it's just not in a viable place. Then on examination, you get abdominal tenderness, unilateral adnexal tenderness, and possible an adnexal mass. And then signs of a ruptured ectopic. Can anyone think of any signs of a ruptured ectopic? Peritonism, yeah, peritonism, nausea and vomiting. Yeah, so ruptured ectopics present with often hemodynamic instability. So the woman will have pallor, she'll have tachycardia, hypertension, dizziness, nausea and vomiting, and you get right shoulder tip pain. Does anyone want to hazard a guess? Yeah, why you get right shoulder tip pain? Miguel's just suggested it, but why do you actually get the right shoulder tip pain? What causes it? Diaphragmatic irritation, exactly. So basically it's referred pain. Yes, it's referred pain due to irritation of the diaphragm from blood in the peritoneal cavity, which is caused by the ruptured ectopic. Yeah, well done, guys. You all got it. So abdo exam, you will get peritonism, which can present with rebound tenderness and guarding. And then on vaginal examination, you'll get tenderness. You might get cervical excitation and then blood in the vaginal vault. So they're just like important things to be aware of. Okay, so investigations. You firstly need to do a uterine pregnancy test because if the woman's positive, then you can be thinking ectopic pregnancy. If the woman's not positive, then you don't need to think about an ectopic. So that's the easiest and the first test you should do. Then you should do a transvaginal ultrasound. And basically this is when you're looking for the pregnancy outside the uterine cavity. So there are different signs that you can see. The donut sign, which if you can see that little picture there, looks like that. And basically it's just like a mass next to the ovary. And that's the donut sign. You can get a ring of fire sign, which is basically increased blood flow to the ectopic, and that is seen with a colour Doppler. And then you can get the free fluid in the cavity, which basically just suggests an ectopic, or it suggests rupture. And if you're looking for an ectopic, it could suggest a rupture of an ectopic. Does that make sense? And then the last examination you would do is serial HCG levels, and basically they will either increase, but not by a lot, or they'll plateau. So that is key things for ectopic pregnancy. Okay, back to our case. So the ectopic is diagnosed, and when discussed with Miss Jones, she is unkeen for surgery and would like some form of treatment for her pain, as her pain is getting worse. Her beta HCG is 1,500, and other than the pain, she seems well. So can anyone suggest the different treatment options and suggest what would be most appropriate for Mrs. Jones? Okay, we'll start. So expectant management is used if it is the woman is low risk, if she is stable, if it is unruptured, if she is asymptomatic, or if she has very, very mild pain. If women have pain, you're unlikely to go down this route. Or if she's very mild pain and she like convinces you really hard, then maybe you consider it. If the beta HCG is low, so less than 1,500, if it's decreasing or if it's plateauing, I will just say the figures that I have used for beta HCG vary a lot between different sources. I think the ones I have used are from the top guidelines or from the obstetricians and gynae website. Don't get too caught up on it because they differ between like NICE and all the different sources. But generally, if it's lower, if it's the trend is decreasing or if it's plateauing, then you'd be more likely to consider this. You basically do nothing and wait for the pregnancy to fail, because most ectopic pregnancies will fail because the blood supply in the location is not enough to support the growing embryo, so the embryo will die. That is basically what happens. And what you have to do is monitor the HCG levels every 2 days to ensure that it's falling until it's undetectable. And this usually takes 2 to 4 weeks. So these women will come back to hospital every 2 days to get their beta HCG read via a blood test and to see what level it is. Basically, any questions about that? If you do, you just pop them in the chat. So the next management is medical management. So this is used for medium risk women. If expectant management has failed, which basically means if the woman's got pain now, or if the HCG level is not dropping, or if it's rising, but they're still stable, the pregnancy is unruptured and they have low HCG, so like less than 5,000, and there's no fetal heartbeat. And basically you give IM methotrexate, which is an antifolate agent which prevents cell division, and then a second dose can also be given on day 4 if the level's not dropping enough, but you can only give 2 doses max. And then again, you monitor the HCG levels every 2 days until it's undetectable, which usually takes around 2 to 4 weeks. And women must avoid getting pregnant again for 3 months. Does anyone know why? Anyone, any ideas why? So it's not risk of another. So yes, it is not. Yeah, not necessarily risk of another ectopic, Izzy. It's as other people are saying, methotrexate is tetragenic and it's an antifolate inhibitor, so you need to wait for it to go out of your system. And you give and even though you're only giving 1 dose, you're giving quite a high dose. So you have basically, methotrexate has a risk of neural tube defects and other things because it is an antifolate. So, and you give quite a high dose, so you've got to wait for that whole dose to be out of the system. So the advice is to wait 3 months. So even though it's only 1 dose, seems like quite a long time. But that is what the advice is. And the last management is surgical, which is used for high-risk women if the woman is unstable. So she's got, like, for example, she's got symptoms of like low blood pressure, she's being nauseous a lot, that kind of thing. If expectant and medical management has failed, so again, if the beta HCG is not dropping, if there's hemodynamic instability, so those features we mentioned before, like hypertension, tachycardia, if there's signs of rupture, so shoulder tip pain or any of those other features, if the HCG is also high, so higher than 5,000, if the fetal heartbeat is seen on a scan, so even if the woman is really well but you see a fetal heartbeat, you need to go down surgical management, or if there's an adnexal mass of more than 35 millimeters. In that case, you need to go down surgical management route. So there are 2 different options. I am probably going to butcher the pronunciation of these, so I'm really sorry. The first one is laparoscopic, as you can see, basically splanectomy, where you take out the whole tube and the ectopic. So, for example, you lose the whole left fallopian tube. This supposedly doesn't affect fertility if the contralateral tube is fine. So if the right tube is working perfectly, you can take away the left tube and there's no decreased chance of fertility. And it's the most common approach because it's got like the best outcomes, because you're more likely to get all of the ectopic out. And after this, you do a pregnancy test afterwards and it should be negative and then it's fine. Or you can do the same like laparoscopic procedure, but you do a saphengostomy. So you basically preserve the tube and literally like cut out the ectopic from the tube. So you just leave the whole tube in place and you cut out the bit of ectopic. And this is done if the contralateral tube is damaged. So for example, if you've had a previous ectopic and you don't have a contralateral tube, or if you've had PID before and the contralateral tube's got lots of scarring in or something like that, then this procedure will be done, or if the woman really, really requests it. But it's not advisable because you can leave like scarring in the tube, which then makes an ectopic more likely next time because there's some damage to the tube, if that makes sense. And for this, you will do serial HCG levels until it's undetectable because you've left the thing, like you could have left some of the tissue in there, so you just take out part of it. So you have to do HCG levels. And important to note, no, not important to note, that's something else later. You give anti-D for, this is important to note, you give anti-D for this. So no matter what gestation the woman is, because it's a surgical procedure, you will give anti-D prophylaxis if they're rhesus negative. Okay, now we're going on to miscarriage. Oh, no, well, hold on. We'll just talk about some complications first. So as someone said earlier, ectopic can cause rupture and you can get interperitoneal hemorrhage. And if this isn't controlled because of the hemorrhaging you're getting, you can get death. So it's quite a scary complication. It's very rare. When I was on my obs and gynae placement, there was a woman who had had a ruptured ectopic and she'd been transferred to ITU in a coma after, I think she lost like 3 litres of blood into her abdominal cavity before they realised that she'd had a rupture and before they could get her to theatre to stop it. So it was very rare and she was like super unwell and they were like, this never ever happens. So that's quite a rare complication, but it can happen. Then you can get tubular infertility, obviously, because you've got the scarring from the different procedures or from the methotrexate or from the expectant management, you can get scarring occurring. And then the risk of recurrence. Does anyone want to hazard a guess about what the chance of recurrence is? Okay, it's around 15%. So it's like quite high that the risk you'll get another ectopic. So just like something to be aware of if you're ever presenting a case or doing something or taking a history from someone and they've had a previous ectopic, it should be like a strong consideration they might have another one. Okay, so miscarriage is the involuntary spontaneous loss of a pregnancy before 24 weeks gestation. So basically before the fetus reaches viability, and this is the definition in the UK because it differs between different places. So an early miscarriage is before 12 weeks and a late miscarriage is between 12 and 24 weeks. And miscarriages occur in 20% of pregnancies. So 1 in 5 pregnancies end in a miscarriage, which is incredibly common and it's not talked about that much. But like that is a significant proportion of miscarriages, of pregnancy, sorry, are do not reach term and are miscarried. So an early miscarriage is the most common type of miscarriage and it accounts for like 96% of all miscarriages, and these are due to embryo abnormalities. So does anyone want to hazard a guess? I mean, you can see my list there, but anyone want to hazard a guess at what the most common cause of miscarriage, of early miscarriage is? Like the most common embryo cause of early miscarriage. It's on the screen. Edwards is not Edwards. So as far as I'm aware, the most common cause is trisomy 16, which is probably not something you've ever heard of, and that's because it's non-viable. So, but it's a very common thing to have that causes miscarriage. So chromosome abnormalities like Downs, Edwards, Turner's, and trisomy 16 are all common causes of miscarriage. Then genetic abnormalities, and then structural ones like spina bifida, congenital heart disease, and any CNS issues like anencephaly and other ones where the brain and the skull aren't formed properly. So risk factors are a previous miscarriage. Having a multiple pregnancy makes it more likely for a miscarriage. Infection, so like the torch infections. Does anyone want to know what the torch infections are? Anyone? Toxoplasmosis, other, rubella, CMV, and is the last one HIV? I can't remember. I think it might be. So they can all cause miscarriage and are important things to ask about and think about. And then also older age women. So if you're older, you're more likely to have a miscarriage. If you're a woman's obese, if they smoke, if they've got diabetes, thyroid disease, and PCOS, they all increase the risk of miscarriage. So late miscarriage is between 12 and 18 weeks, and this accounts for 4% of miscarriages, so it's much less common. And they're mostly due to maternal factors, so infection, which causes then transplacental infection of the fetus, so like ascending infections. This is why pyelonephritis is really dangerous in pregnant women, and any like STI is dangerous because it can ascend up. Uterine abnormalities, so things like fibroids are the most common one. Cervical problems like weakness, incompetence, or insufficiency, and these can be pre-existing conditions, or they can be due to invasive procedures. So both chronic villus sampling and amniocentesis can cause cervical weakness, which can then precipitate miscarriage. It's one of the, I think they've got like a 2 to 3% chance of miscarriage, and that's something women have to be like aware of before they undergo the procedure. And then so coagulopathies like antiphospholipid syndrome, thrombophilia, like factor V Leiden deficiency, and those kind of things. And then rhesus immunization is not so common anymore in the UK, but it's common in other places in the world. So risk factors again include invasive procedures. So as I said before, chronic villus sampling, amniocentesis, cervical cone biopsy. Does anyone know what you do a cervical cone biopsy for? Yeah, so cervical cone biopsy is done for cervical cancer, like low grade, so like stage 1, and it's also done for cervical in like CNN stages 2, 3. Normally you do it as well. So that's like precancerous lesions, you do it, and also for low grade cancers you can do it. And then again, multiple pregnancy. So types of miscarriage. This is a very busy slide. These are the main types to know about. We'll just quickly whiz over them. So a threatened miscarriage is when you have PV bleeding, but the fetus is still viable, so the pregnancy can continue. So when our lady presented at the start and, you know, she's pregnant and she's got PV bleeding, it could be a threatened miscarriage in the fact that she could miscarry, but also she could just continue the pregnancy and it might just be like physiological bleeding. So the os is closed and the fetal heartbeat is still viable. An inevitable miscarriage basically means the miscarriage is occurring at the moment. So you have bleeding, you've got pelvic pain, and the cervical os is open, and there's no heartbeat anymore. So that means the miscarriage is happening, and that's it. Incomplete is when some products have been expelled, but some products of conception remain in the uterus. So you have bleeding and open cervix and a fetal heartbeat, but not all the products have gone yet. And this can get infected. So incomplete miscarriages need treatment. Complete one is when all the products of conception have been expelled from the uterus, the symptoms are resolving, the os is now closed, and the uterus is empty. So a missed or silent miscarriage is basically when the pregnancy has failed but has not been expelled, so the body has not reacted to the fact that the pregnancy, the fetus has died. So you have no bleeding, the os is closed, and there's no heartbeat, but you don't have any symptoms, so you've got no pain, no bleeding, no nothing. A septic miscarriage is basically when the mother has some form of infection and that has precipitated the miscarriage occurring. So as I said earlier, pyelonephritis, PID, anything like that. And then recurrent miscarriage is 3 or more miscarriages before 24 weeks. And once you've had 3 or more miscarriages, you can get referred and they'll do all these testing for things like antiphospholipid syndrome and all that kind of thing, and start investigating to see why you can get pregnant but you can't continue the pregnancy. Okay. The other thing that now to put that in a minute. So for pregnancy, miscarriage, you will do a pregnancy test again to confirm that there is or was or has been a pregnancy. You do a transvaginal ultrasound to confirm it's non-viable and identify what's going on. So to see if the os is open, and to see if the products are still there, if they're not there, if there's a heartbeat, if there's no heartbeat, and then you'll do serial HCG levels and they will drop by over 50%. Okay, we have a new case now. I'm just going to have a drink, so start reading. Okay, so she's been diagnosed with a miscarriage at 11 weeks. It's her 3rd miscarriage in 2 years. She's previously managed them without any treatment. She's well on herself, and this is the only history of no other than rhesus D negative status she has heard, and that the products of conception can be tested, and I was wondering if this is possible, and if so, how will she be managed? So, has anyone got any ideas of the different treatment options? They're similar to ectopic, that's a clue. And she says in the before that she's not had any treatment before. In the case, sorry, it says she's not had any treatment before, which is also a clue. Anyone got any ideas? Pop that in the chat or turn your mic on if you want to. Okay, we'll just go through them. So the first option is expectant management. And this is basically used if it's maternal choice and if you're less than 13 weeks. If you're over 13 weeks, this is not advised and medical staff will be strongly against you doing it. So the pregnancy tissues are expelled spontaneously. Basically what happens is a bit like in an ectopic where you just let the pregnancy fail, you just let the miscarriage pass out. And it can be continued for as long as the mother wants, but the advice is that after 14 days, if there's still products of conception remaining, you go down a different route because it's unlikely that it's going to be successful. So you rescan at 2-week intervals until a complete miscarriage is diagnosed. You can give the woman analgesia, anti-D if they're beyond 12 weeks, obviously not very commonly given because they don't recommend it if you're beyond 13 weeks. And you should offer women counselling because having a miscarriage is a very traumatic procedure. Not procedure, it's a very traumatic time for women. And then you do a pregnancy test 3 weeks after the bleeding stops and the bleeding and the pain have stopped. And this is just to check that the miscarriage has definitely, you definitely miscarried. So the next option, as McGill said, you can do medical management, which is also used as a maternal choice. So some women will want something to be done. They don't want to just wait for the miscarriage to pass, but they don't want surgery. So you might do this option. And it's used if expectant management fails. So that basically means the woman's still getting pain or the miscarriage has not been successful after 14 days. You give intravaginal misoprostol, 800 micrograms. I'm not sure if you need to know that, but and this is a prostaglandin E analog, and it basically stimulates ripening of the cervix and then causes myometrium contractions, which basically causes passing of the products of conception. And you can give a second dose on the 3rd day if expulsion has been incomplete. It's a bit like methotrexate, but you give it a day before in ectopic pregnancies, so you can give another dose if needed. And then you also give analgesia, you can give anti-D if beyond 12 weeks and offer counselling, and then you do a pregnancy test 3 weeks after the misoprostol has been given to check that the pregnancy the miscarriage has passed. And then surgical management. This is used if it's maternal choice, if expectant or medical management has failed, so there's ongoing symptoms after 14 days. And it's also used if you want to get a sample. So in this case we did here, where the woman wanted to get a sample to be tested, you would use surgical management. Sometimes with medical management you can get a sample. It's very difficult, so you wouldn't really advise it. But with surgical management you get a sample because the products are extracted into a container effectively, and that can be sent to the lab for testing. So that is also when it will be used. So for example, if after this is the woman's 3rd or more miscarriage and she wants it to be tested, or you advise her to get it tested, then you would often go down the surgical route because it's the best way to get a sample. So basically there are 2 different methods for evacuation of retained products of conception, and both of them effectively involve a tube, like a suction tube, going into the uterus which removes the products. So you can do one, which is manual vacuum aspiration under local anaesthetic. Having watched this, it was horrible, but some doctors will do it. Otherwise you can have surgical management under general anaesthetic, which is often done if the pregnancy is a bit smaller or they're less far along, because you can ultrasound at the same time and you can be slightly more aggressive in your attempts and you won't cause the woman as much pain because they're sedated, fully sedated. So if it's not all removed, you can go back in for a second procedure. And you often give antibiotics, especially if there are signs of infection. So if there's foul smelling discharge, fever, chills, if a woman's generally unwell, then you will give antibiotics. But then you also give analgesia. You give anti-D at any gestation. So even if they're earlier on, you give it. They don't advise surgical management for less than 7 weeks because usually the products of conception are too small to viably get, and it can be difficult to know if you've actually got them. So they don't really advise it then because it's likely that you might miss some and have to go back again. And then you also offer counselling. And then it's important to say that, as I said earlier, you can get cervical incompetence. So if this is what happens in future pregnancies, you can do something called I can't remember what it's called now. It's like a sur lavage, where basically you suture the cervix together so that it can't open effectively. And then these stitchings are usually like taken out around 37 weeks, when the pregnancy can then obviously so that the mother can go into labour naturally. So that's something that can be done if she's had many miscarriages and it's down to like cervical weakness or incompetence. And just one more thing to say, if I know I said you can send the products for testing, so for this you can do karyotyping of the fetus to look for like chromosomal and genetic abnormalities, and then you can also try and look at the placenta for signs of infection. So there's one type of infection which causes micro abscesses in the placenta. I can't remember what it is. I feel like it could be rubella, but I can't remember. Does anyone know? It's like characteristic, but off the top of my head I can't remember. It causes micro abscesses in the placenta. So that's one thing you can look for in the if they've had many miscarriages and you're testing the products of conception to see if they've had this infection. And then you can also test the mother. So you can do full blood count using these thyroid function tests, liver function tests, like clotting. You can do thrombophilia screen. You can look for autoantibodies, so lupus coagulant, antiphospholipid, anticardiolipid. You can also look for do torch screening and look for infection. So you can do like vaginal swabs and blood cultures and that kind of thing. You can also do a uterine ultrasound and look for any like fibroids or cysts or anything in the uterus that could be precipitating miscarriage. And then you can also do karyotyping of both the parents to see if they have any like translocation or something that they could be passing on. Okay, does anyone have any questions about that? I know we've gone quite quickly. If not, we will go on to gestational trophoblastic disease. And this is a tumour of trophoblastic tissue. And the trophoblastic tissue is part of the blastocyte, which normally invades the endometrium. And in gestational trophoblastic disease, the trophoblastic tissue basically proliferates more aggressively. So you get benign tumours, which are the mode of pregnancies, and these can be complete or partial hydrodat moles. And then you can get malignant tumours, which is the gestational trophoblastic neoplasm. And these are the four main types of them. We're not going to talk about those because they're not as important. They're super, super rare. I mean, mode of pregnancies are super rare, but these are super, super rare, and they'll be sent to like one of the like 4 specialist centres in the UK. So it's not something you will ever really see and need to worry about, but you should be aware of molar pregnancies. So can anyone suggest? Oh, no, in a second. So molar pregnancies are caused by an abnormality in the chromosomal number. So a partial hydrodat mole has one ovum, which has got 23 chromosomes. It's fertilized by either 2 haploid sperm, each with 23 chromosomes, or 1 haploid sperm that then doubles. So basically it's got 69 chromosomes, which is way too many, and it can either be XXX, XXY, or XYY. And then a complete mole is basically when you have an ovum with no chromosomes at all, and you get a 1 haploid sperm that duplicates, or you get 2 haploid sperm, which is less common. Usually it's 1 that duplicates. So this has the right amount of chromosomes, but they're all paternal in origin. And this has a higher chance of malignancy than a partial hydrodat mole. Does that make sense? Because this took me ages to get my head around. They're not very common, and they're basically just due to the chromosomes, like messed up chromosome numbers and in a weird chromosomes coming from weird places. Okay, I'm going to go with that makes sense, but if it doesn't, please let me know. So can anyone suggest any symptoms of gestational trophoblastic disease? Any symptoms? Vaginal bleeding, good one. This lecture is on early pregnancy bleeding, so Okay, so you can get vaginal bleeding, which is probably the most common like symptom that they present with. You can also get hyperemesis, which is they get worse, like bad hyperemesis, and this is due to the high levels of beta HCG that they get. And then you can also get hypothyroid, which is a really rogue one, and it's basically like, I think it's extremely rare, but in SBA land it's not that rare, but it is actually extremely rare. And it's basically due to stimulation of the thyroid by high levels of beta HCG, because at really, really high levels, the beta HCG mimics thyroid stimulating hormone. So you basically get hypothyroid because the beta HCG is so high, but it's really rare. And then you get like an unusually large uterus for the gestational age. So like the uterus will be massive. So like, when does anyone know normally when the uterus comes up to the belly button? Yeah, it's around like 20, 22 weeks. These women may present like at 6 weeks or 8 weeks gestation with uteruses like up to their belly buttons, which is way too big. So like if they're massive beyond gestation, like that is something to consider. And you have like a soft, boggy uterus with like weird consistency, basically. So to investigate, you do you do serial HCG levels with marked elevation, which has got marked elevation for gestation. Then you do a transvaginal ultrasound. So a complete mole will look like this, which is like a snowstorm appearance in the uterine cavity. And there's no fetal parts at all present. Whereas in a partial mole, you might have like a small placenta, and you can get some partial fetal development. So you might get like, you get blood vessels and you can get some placenta and some kind of outline of a fetus, but it's not like anything like an actual fetus should be. And then all the products of conception should be examined histologically to kind of work out if it's a partial mole, if it's a complete mole, and like how the chromosomes are like made up, if that makes sense. So beware of that ultrasound. It looks really weird, but it's characteristic of a complete mole, a pregnancy. Okay. And then it's also important to say that in terms of the HCG, sorry, I should have said this earlier, it's often, when I say it's really high, like it's often as high as 100,000, which is like ridiculous. But that is why you get really bad vaginal bleeding, really bad hyperemesis, and can get the hypothyroid. And then also with the HCG levels, you can monitor it because so when I said you can get gestational trophoblastic neoplasms, that is called, like the sign for that is like a persistently rising or consistently high beta HCG. So normally the beta HCG kind of like peaks in the molar pregnancies, but in these ones it like literally just keeps going up if there's malignancy. So management of a molar pregnancy, you basically want to like remove the tumor effectively, because that is what the pregnancy is. It's like cancerous, well, not cancerous, but it's tumorous. It's a benign tumor. So you can do ERCP, so basically a suction tube into the uterus via the cervix, like sucks out the tumor. And then because these women have massive uteruses, you also give oxytocin to try and aid the involution of the uterus. So that's not normally given for like ectopic, not for miscarriage, but you would give it in this situation. And this is used if fertility is desired, and women need to be on contraception for a year afterwards before they try and conceive again because of the risk of a recurrent molar pregnancy. Or you can do a hysterectomy, which is like the preferred method of choice, but this is only done if a woman's completed her family or doesn't want to have a family or anything like that, because it decreases the risk of recurrence, and it's just much safer because you're much more likely to get out all of these tissues. And then you should give anti-D prophylaxis as well. If it's malignant, you give methotrexate at a chemotherapy dose, so it's much higher than the dose given for ectopic pregnancies. But this is done in a specialist centre, and there's nothing you will like ever see. Has anyone got any questions on that? Any questions? I'm just going to try and load this Menti thing quickly. However, I have a feeling it's going to say the voting is closed, and I don't know why, so we'll try. Any questions? Okay, we might not be able to do it on Menti. We'll give it a go, but it's probably going to be closed. Oh, someone's asked, with miscarriage, will we be expected to know the specific findings on ultrasound, like fetal? No. So I did have those written down, and then I kind of got rid of them. So on a miscarriage, I know, yeah, on a miscarriage, there are certain measurements which indicate there's a miscarriage has occurred. I can't remember them off the top of my head. I don't think you'll need to know them, no. Because the other thing is they differ between like different places that you look at, and I think different hospitals have somewhat different guidelines. So I wouldn't worry so much about the measurements. It's more about what's actually happening in the woman. Like, are there some products of conception? Is there a heartbeat? Is there a mass? Is there that kind of thing? Let me just try and find the measurements that I had. But I wouldn't worry so much about them. It's more about the symptoms and everything else that happens. Miscarriage. So I had the crown rump length bigger than 7 millimeters, or gestational sac bigger than 25 millimeters with no heartbeat or anything. But I don't think you need to know that. So, okay. This is supposedly the Menti code, but I have a feeling it won't work. So we'll just go on to the slide with the question. So Lily has come in with 2 days of vaginal bleeding. Her last period was 5 weeks ago, and she took a pregnancy test last week, which was positive. The transvaginal ultrasound was performed, but nothing can be seen. Her beta HCG is taken and is 800. She has no pain and is bleeding minimally. She goes home and comes back 2 days later. Her repeat HCG is 1,750. Okay. Has anyone opened Menti? Does it? If it doesn't work, it doesn't matter. We can just wait. I feel like it's not working. Oh, hold on. Wait, am I? Okay, now it's the right question. Sorry. I'm not very good at tech stuff. Normally Anush helps, but he's gone, so. Okay, we're going to give up with the Menti. Oh no, hold on, people are voting. We're not going to give up with Menti. It obviously worked, which is some stroke of luck, because... Okay, most of you have got it right. So, this is a viable pregnancy, and the bleeding is probably physiological. So because if you look, the beta HCG has more than doubled. It's more than doubled, and it looks like it's probably a viable uterine pregnancy, and she's just, as I said, got physiological bleeding. So what you can do in this situation is do nothing, and you'd rescan her in probably 7 days time and see if you could see anything. Especially as her last period was 5 weeks ago. She's approaching the point where you probably will start to be able to see something soon. So you'd rescan her in 7 days and see what happens. So a hysterectomy, as I said, you only really do for a molar pregnancy. That's very extreme. Methotrexate is for medical management of ectopics. Intravaginal progesterone is medical management of miscarriage. In this situation, it doesn't look like it is a miscarriage. Does anyone who voted for miscarriage, you don't have to if you don't want to say why they thought it was that. And then laparoscopic splenectomy is a surgical management for ectopic, which this does not appear to be because it's doubling. Okay, we'll go on to the next question. If there's no questions. Okay, so Fionn has been treated using methotrexate for a molar pregnancy. She had a very large uterus, and given that she was only 7 weeks was experiencing heavy vaginal bleeding when she was diagnosed. She was eager to get pregnant again, and she would like to start a family. What is the most appropriate advice to give her? Just let me change the question on Menti. Try and work out how to change it on Menti. Okay, I've changed it. What's the most appropriate advice? Okay, the answers are very torn. However, if you remember me saying, I sneakily threw it in, that in a molar pregnancy, you have to wait a year to get pregnant. And this is because the risk of a molar pregnancy recurring is 1%, which is not that high. But if you get more than one molar pregnancy, so if you have 2 molar pregnancies, the risk of recurrence is 20%, which is quite significant. So the advice is to wait 1 year before you get pregnant again. This is also because they want the uterus to fully involute, and they want everything to settle down to thoroughly reduce the chance of getting a recurrence. And when you do get pregnant again, you'll be followed up by in obstetrician-led care, like by a consultant, and you will have regular HCG monitoring in the start of your pregnancy to check that it's not a recurrent molar pregnancy. So methotrexate for 3 months is in ectopic pregnancies, not in molar pregnancies. So yeah. Right, that is all I had for today. Has anyone got any questions? Please let me know, or if anything didn't make any sense or anything like that. And if you could also fill in the feedback form, that would be really helpful too. Oh, Anoush is back. Do you still want me to stop the recording, Anoush?
I'll do it. Just give me a second.
Sorry, my internet went for a tiny bit, I think.